Dr. Ritu.
Thank you so much, Dr. Nitin, for having me here. And I'll be talking about the management of rock hard cataracts. These are challenging cases for even very experienced surgeons. And I would say it's a relative term depending on your experience and confidence. So, what may be hard for someone may be a relatively easy surgery for the other. But all these cases, as you can see, they are of different types. And the main challenge in such a case is that there's a lot of compactness and hardness to the nucleus, and there's hardly any epinucleus cushion. So a thorough preoperative examination is important, where you must look at the grade of the cataract, whether it appears leathery or morgagnian, whether there are any plaques or is there any phacodonesis or pseudoexfoliation, are there any comorbidities, and a good look at the pupil dilation, because that is going to help you to plan your surgery, and the AC depth. Of course, a B scan, for the posterior segment evaluation, and such cases where, even your optical biometers will fail. So a contact or immersion biometry is important. Taking a history of tamsulosin again will help you to plan your surgery. And if you have access to a specular microscopy, that's good for knowing the endothelium health. Rexus is the nemesis, and my previous speaker has already very beautifully illustrated how one should do. As she said, always, always stay in these cases. Because they have weak zonules, they could have plaques, and you must have a good sized rexus, because these hard cataracts are going to require a lot of chopping. Using a good cohesive viscoelastic, using the soft shell technique is good. And I would say keep your ego aside whenever you're doing such cases, no matter whether it is your 1,000, 2,000, 20,000. Ego must be kept aside. If you feel more comfortable with a block, please go ahead or shift to a subtenous block midway during surgery. More than anything, you be calm so your patient also remains calm. So I'll just show you, actually, I may just, skip some of these Rex's videos because they've already been shown so well. But I also prefer to go in with a needle, although, one should be well versed with Rex's faucets. A little, another case which is actually quite an intumescent cataract, but it also has a very nuclear, hard nucleus looking behind. And again, as soon as you blink, you can see Rexus when you're doing your chopping. So again, this is again another case which has a very fibrotic plaque, and the important part is to go around the plaque, because you cannot sometimes the plaque is so dense, you may have to. So if you have access to flax or femto, of course, that's good. You have a double advantage. You can do your Rexus and you can soften the nucleus also. Or a Zepto, again, is a very convenient way of doing it. And coming to the phaco maneuvers, it's good to do a temporal if you're comfortable with it, or if you feel you're a beginner and you may want to convert, then a superior incision would be better. Hydrodissection should be extremely gentle, multi-quadrant, and very small aliquots, because you hardly have any epinucleus. And a liberal use of OVD, as I already mentioned. You must do more of phaco chop techniques rather than go for sculpting. Minimize the phaco energy, use the burst or hyperpulse, and use your torsional or transverse ultrasound. A high vacuum, high flow rate surgery is always better. And my loop is another thing. I don't have a personal experience. I tried it out, but I was not comfortable with it. And at the same time, be ready to bail out. Be prepared for all eventualities, a CTR, pupil expander, keep your anterior vitrectomy on standby, don't be hesitant to convert, and always be watchful for the ominous signs like the pupillary snap sign, or the sudden deepening of the anterior chamber, or tilting of the nucleus, or suddenly you see an area where the glow is more. So there's always an insight as a surgeon that you have that something is not right. And at that point, you must always stop, reconsider, or even call out for help. So I'll just show one small video because I really didn't have time when Dr. Nitin told me. I just took out one of these videos. So as you can see, it's a dense cataract with very poor glow. You must stain your capsules. Do your rexes, as I said, a good sized rexes is required. And after you've done a gentle hydro, of course, there are many ways to skin the cat. And I prefer to do a chop technique, but at the same time, my go-to technique mostly is the flower petal technique. Many other techniques have been described, like the terminal chop. I also like Dr. Pradeep Mohanta's submarine chop. And here you can see I'm making several peripheral chops, trying to use the natural lines in the lens to separate the leathery cataract. And don't be over exuberant. It's okay to make small cuts and use multi-level chopping. Try to go deeper and gradually tease the leathery fibers apart. In fact, contrary to most people, I like to keep my posterior plate intact rather than have a complete cut, because I feel that protects your flaccid posterior capsule. And the central part of your nucleus, once you've done the multiple chops, you can have almost a ball coming out at times, which can be, emulsified. And so here also repeated injections of viscoelastic are important. And here you can see how I'm teasing it into the center, amputating the periphery. So you're, actually cutting off, you can say, the petals. So one by one, you do the chop, bring it a little bit into the center, and then use your chopper to amputate the central part. So that way all the periphery gets cleared up, and in the end you have a thin posterior plate kind of thing which can be then emulsified. I'll just fast forward in over here. So you must be patient and take, the pieces are small. Try to make as many small pieces as possible. And keep filling the anterior chamber with viscoelastic as and when required, so that you keep protecting your endothelium. Okay, it's almost done. And be slow in the end. The last few pieces, you can reduce your parameters and look for any lurking pieces here and there. So you've got a good surgery, a nice clean capsule, and there was actually no need for doing an IA because there was no cortical matter. And you can see the wound is also clear. There's no wound burn in such a case. Always go behind, remove the excess visco, and I'm sure you'll have a good result in the end. Thank you so much.